Are you okay to start with this case?
Yes,
Okay.
that's fine.
All right.
Okay, we have a 42-year-old male. He came into the health center from Union Mission, and he is in rehab right now. He's single, has a son and a daughter that are grown. He said he started using opiates in his 20s to early 30s, but this use was sporadic, did not have a hold on him until his mother passed away when he was 35, and he started using Oxy 80s and then on to IV heroin when he couldn't get the Oxys. Also was using IV meth. In November of 19, he was arrested for domestic violence and was put in jail where he got clean. And then he went straight to Union Mission and had just found out he had Hep C. This man is on disability. He said he fell down 18 metal steps when he was 2 years old, and that was the first brain injury. Then he mentions other injuries where he was hit in the head with a baseball bat and then a wrench on the forehead. So he's had a number of injuries, but he doesn't work, but he definitely wants to get the Hep C taken care of. His health problems, when I saw him for the first time, was he does smoke. He has a vitamin D deficiency. And right after he came, he had a left inguinal hernia repair. But otherwise, he's pretty healthy. I can relate to him easily. He's doing well in recovery. I did have him on vitamin D3, 50,000 units weekly, and ibuprofen is needed. He is immune to Hep A and Hep B. His ultrasound showed normal size, contour, and echogenicity, no lesions, horseshoe kidney configuration. So you can see his weight was 212, height 73 inches. And his blood work, hemoglobin was normal, hematocrit normal, platelets, white cells, glucose was 105. His ProTime and INR was normal, albumin 4.7. Liver enzymes, ALT 89, AST 61. And I calculated his APRI to be 0.537, the child Turco 5, and MELD score was 7. His iron levels were all right. His vitamin D then came up to 37.3, but we were continuing to get that a little higher. HIV negative, his genotype is 3, and his viral load was 664,000. Fibrosis marker is 0.04. And other lab, I forgot what that was. Let's see. I can find that. So my, what I thought that he might do okay with was Mavorite or Epclusa, seemed to be the choices. And I just put his first Hep C quantitation was 273,000. And I wondered if we would need to do ultrasounds on him, and with having the horseshoe kidney configuration cause any risk. I think that's it for now. I'll take feedback.
That was excellent. Thank you so much, Tammy. Before we jump into any recommendations and everything, did anyone in the group have clarifying questions for Tammy? All right. Any other comments, feedback, recommendations? I'll open it up to the group.
This is Kaylee. I'll talk if nobody else wants to, but certainly if anybody else has any feedbacks, please go ahead of me. If any of the has any questions, I'll let them talk first. But Tammy, thanks so much. You have been rocking with cases, girl.
Yeah.
I'm so proud. Like, are you just getting an influx of cases, or are you screening more? Are you just presenting more now? Because you're rocking. You've sent what, like 4 in a couple weeks?
Yeah, 4 probably in a month. And
Yeah.
is I've had several, and they are, just getting worked up to the point where they're ready for treatment.
Great. No, that's wonderful. I think keep sending them.
I will.
Good. Yeah, so you're spot on with your treatment recommendations, either Mavorite or Epclusa for him. 8 weeks for Mavorite should be reasonable. Epclusa would be 12. So honestly, it'll really just come down to your discussion with him as far as does he, is he going to be successful with taking the 8-week treatment with food? Or does he not want to worry about having something on his stomach and would rather have a longer course of treatment, but not have to worry about the food component? But otherwise, it's truly up to you guys, because his insurance should cover both. He's not somebody that I would feel strongly about needing to get routine follow-up imaging, since there wasn't any suggestion of advanced fibrosis on any of his prior or pre-treatment testing. The mild fatty changes, if his liver enzymes don't normalize during or after Hep C treatment, you may want to continue to follow that, and then possibly do a liver ultrasound in a year more for his monitoring of his fatty liver disease. Jean's going to talk about all that today, so she can correct me if I'm wrong, but that would be my approach, but not so much for cancer screening. It would be more so for monitoring of his liver disease. And then your question about the horseshoe kidney is cool. Mel Gibson has a horseshoe kidney. I guess it's not very common, but I guess there's a celebrity that's got one. So I don't know why I know that, but I did. So I think, I don't know if he's seen urology at all or ever had that evaluated, but I wouldn't necessarily think it would pose an increased risk for hepatocellular cancer or any Hep C related issues, but he is at a little bit higher risk of UTIs because of that abnormality, and even some types of renal cancer. So if he has never followed with a urologist, it just may be a good idea for him to at least see one, so they can kind of counsel him on what he needs to be looking out for, and kind of measures he can take, like I don't know, if he has trauma, he can have, to his abdomen or abdominal surgery, he can have kind of more complications because of the horseshoe kidney. But other than that, I don't think there's really anything you need to address specifically with that condition, or anything related to his Hep C with that condition.
Okay.
Thank you, though. That was a great case.
Yeah.
Thank you, Kaylee. Any other comments or feedback for Tammy? And Tammy, were there any other questions you wanted to ask about this case in particular?
No, I think she answered everything.
That's excellent.
Yeah.
All right, great. So are you ready to move on to your second case?
Yes, ma'am.
All righty, so let me pull it up. One moment. All right, and I'll turn things to you again. Thank you.
Okay, this one is a little more complicated. So This is a 46-year-old male. He has a history of drug use since his late 20s or early 30s. He started out using cocaine, then meth, and then opiates, mostly IV meth and opiates, including heroin. And he overdosed 2 or 3 years ago. And in December of 19, he went into the hospital with a suicide attempt. And it was then that he was told he had Hep C. And he had never been checked, but he ended up also having an MI when he was in the hospital. And the cardiologist actually found the Hep C. The patient states that he's been a roamer. He was originally from Alabama. He was adopted. He said his parents were very abusive. He drove a truck for a living up the eastern United States and came to West Virginia in 2012. He's done odd jobs. He's never been on disability. After he went into the hospital, he decided that he really wanted to live and that he got really mad at himself for doing that. He's currently living in a house with 3 other men, and he does some of the housework and tries to pay for some of his room and board. He is currently smoking half pack a day, and he's been clean since December of 19. So he had 4-way bypass. No, I'm sorry about that. He had cabbage 4 years ago and a non-STEMI MI December of 19 and a stent follow-up in May of this year. He also has congestive heart failure, high cholesterol, hypertension, insomnia, anxiety, and depression, and of course the nicotine dependence. His medications are there, atorvastatin, Brilinta, carvedilol, isosorbide, lisinopril, and then sertraline, mirtazapine for his anxiety and insomnia, and then pantoprazole. He was not immune at the time I typed this, but he had labs right after that, and he is now, I think he's immune to both now. Weight 152, his height 66 inches. There is his CBC, hemoglobin, normal. Platelets are low at 109. White cells okay. His kidney function, liver function is good at this time. His APRI 1.56, Child Turco 5, MELD score was 7. His vitamin D was good, and HIV negative. His genotype was 1A, viral load 4,980,000, and the fibrosis biomarker was 0.85. RA negative, but his Hep B core antibody was positive. He does not ever remember being sick. Or anyone ever telling him he had Hep B. His ultrasound showed normal size liver with homogeneous echo texture, mild fatty change, and no free fluid. I've done drug screens on him every month, and he's been clean. So my question is, should I refer him to GI or ID, given his history of Hep B and his other comorbidities, with possible cirrhosis, or would it be safe for me to treat him? And if so, would Mavorite work?
Thank you so much, Tammy. Certainly a more complicated case, like you said. Did any of the spokes or anyone from the group have any clarifying questions about that case or comments?
This is Jen, and it's sort of testing myself. So I think, Tammy, that's a really interesting case. That poor guy who's like getting a second lease on life, it sounds like. So I'm glad he's seeing you. I would be interested in knowing what his Hep B surface antibody showed. Do you have that?
Yes, it was no, but let me see if I can pull that up.
And then, because I'm thinking that you can treat this guy, and I may be fuzzy on this, and I don't have my notes, but I think that reactivation of Hep B is the risk, and I think if he's surface antibody and core antibody positive, you don't have to worry about that, but I might be wrong. This is like a test. And then the things you have to worry about in the treatment are his pantoprazole and his Brilinta. But I think you can monitor the Brilinta. You can warn, I think you can just warn him about bleeding risk, and with the pantoprazole, I think you dose it at a different time than the Mavorite. But anyway, I don't know how I did. That was like not an open book. So I wanted to test myself and see how much I've learned on Echo. How'd I do, Kaylee?
Yeah. Okay, hold on 1 minute and let me check on that Hep B.
I would have to look all that up if it weren't for Echo, but I think I'm sort of on the right track.
You did beautifully, Jennifer.
Awesome.
While Tammy's looking up the hepatitis B serology, I'll comment on the meds. Jen, I'm proud of you, girl. That's good. I'll tell you, I had to, when I was looking over this case, I had to pull up and plug in all of the drug interactions, because basically all the treatment regimens are going to have some degree of interaction, since he's on an antiplatelet, he's on the pantoprazole, he's on a statin. You know, I'll let Rachel kind of go into the details of each one, but yeah, you're correct, Jen, in that you know, with the Brilinta, there's not really any treatment that's contraindicated. It's more monitoring for signs and symptoms of bleeding because of the narrow therapeutic index with the Brilinta. And then it kind of depends on which agent you're leaning towards. You're going to have to worry about the statin therapy and the PPI, which, you know, with whichever agent that you choose. But because of his cardiac history, I'd be really hesitant to stop his statin. You know, and I don't really have a favored one versus the other. other than I think Zepatier, which probably isn't covered on his insurance, seems to have the least drug interactions. But between Epclusa and Mavorite, because he has Medicaid, I think is what you said, those are probably going to be your two choices. And I think probably the easiest is going to be to dose his pantoprazole with the Epclusa, where you take Epclusa 4 hours before with food. And then the statin, you could keep him on that dose of statin, I believe, but you'd have to just monitor for myopathies and counsel him that it can increase the statin, so he may have myalgias or has a risk of rhabdo. But Rachel, maybe you can comment more specifically on the interactions and what your thoughts are, unless Tammy, you already have your serology pulled up, and then, because that was one of my other questions, was going to be what does Hep B surface antigen and surface antibody showed?
Yeah, well, I did his labs on the 15th, and he is now reactive to Hep B. His surface antibody was reactive. Antigen is negative, and Hep A is now reactive. He's had two Hep B vaccines, so he's good on that now.
And his core antibody is reactive?
Positive, right.
Positive, okay. He's someone, I mean, if he's currently completing the Hep B series, but he already has a prior history of Hep B, you're kind of boosting his response with administering the vaccines, but I still wouldn't necessarily say he's kind of in the clear for not having reactivation, simply because once he's done with the series, there's not really a good way to tell when he'll lose that response. He's somebody I would still check a Hep B DNA on, a baseline DNA. And then when you do treat him, I would still be monitoring his liver enzymes pretty regularly and counsel him on signs and symptoms of Hep B reactivation. If he does have some immune protection, it's not as likely to occur, but he's somebody that if baseline didn't have that protective natural immunity, I would still consider him to be at least at somewhat of a risk for reactivation. Okay. And then the other thing I would consider checking is an alpha fetoprotein. I don't know, I might have missed that. Did you mention checking that on him? You did. Actually, you know what? I think you did. Oh, no. I'm looking at a vitamin D level. So let me step back if you're looking for that, because he's somebody with extensive cardiac disease. This is a gentleman that has an elevated APRI, an elevated fiber test. His liver imaging is optimistic. If you calculate his FIB4, it's also elevated. So you've got multiple modalities that are suggesting this gentleman does have advanced liver fibrosis. His platelets are low. I would treat him as a cirrhotic. It looks like he's stable. I wouldn't be worried he's decompensated, but I would still err on the side of treating him as cirrhotic. He is somebody that I would consider treating sooner than later if you think he'll be successful with therapy to help prevent further progression of his liver disease. I think you should be able to treat him without having hepatology or ID. I mean, there's not really much else we would offer additional than what we're talking about right now. But if it's really dependent on your comfort level. If you think he'll come in for kind of more frequent monitoring of his labs during treatment, then I think you can. I think you can certainly treat him. I would, consider, he's somebody that I would consider doing follow-up imaging on every 6 months, since he is somebody that would be at a little bit higher risk of hepatocellular carcinoma even after treatment. And then just seeing what his kind of baseline AFP is. If his alpha fetoprotein's already elevated, you may want to do a more specific imaging modality like an MRI, just to look for any masses, since his ultrasound didn't seem to even show any concerns for fibrosis baseline. I would kind of use that tool. And then with him, I would also consider an EGD as well, for an esophageal varices screening. Again, it doesn't look like his ultrasound showed any portal hypertension, but he's somebody that's got low platelets and advanced fibrosis and kind of lived a heavy life. So I would feel more comfortable if he had that screening at baseline for those varices as well. But I'll stop talking and let somebody else talk. I definitely want Rachel to comment on the drug interactions, and then if anybody else has any input too. But he's complicated, Tammy.
Yeah.
Still confident you can treat him though.
Okay.
Hey, this is John. Just wanted to bring up a nuanced point that might be interesting. I don't know that we've ever talked about it. And by the way, I agree with everything Kaylee said 100%. I would go Epclusa with the funny timing on your pantoprazole. You know, his, who knows, you're probably going to help his cardiovascular syndrome by decreasing the inflammation of his chronic viremia, et cetera. But hey, when we talk about hepatitis B, the antibody titers, so the Hep B surface antibody titers, there is some potential importance to quantitation. So you mentioned reactive, but I would suggest you get a quantitation of that. If you're just barely positive, which is like 7 to 12 or whatever, versus if you have 700, whatever the unit is. I don't know what the unit of the titer is, but it's a accepted, those numbers are comparable from lab to lab. At least this is a generic concept for hepatitis B. When we look at patients who have had natural history of hepatitis B and we quantify them in terms of their risk of reactivation, the magic number seems to be around 100 for extremely low risk reactivation in any setting. That's even undergoing bone marrow transplant, organ transplant, rituximab therapy, really things that would reactivate most people's Hep B if you have a really high titer to your surface antibody. So Tammy, do you by any chance have quantitation on that besides reactive?
No, I don't, but I can get that.
Yeah, I would get that because, and I agree 100% with Kaylee. This is one of these things where we don't tend to vaccinate our core positives, but and it's going to be hard to interpret. I don't know what to do with it, but I would potentially quantify that one to either increase or decrease your likelihood that you're gonna it's going to cause trouble. Big picture wise, this is exactly the patient, somebody with a natural history of Hep B, where you're gonna and who's cirrhotic. This is exactly the patient population who can run into trouble. And so I my compliments to you for recognizing it, and for Jennifer for the nuanced points you made, and agreed with what Kaylee said as well. So, but see if you can't get that quantitation and let us know. It wouldn't necessarily change anything today or tomorrow, but just interesting and a cool concept. And by the way, that vitamin D must be residual from living in Alabama, because I've never seen a normal vitamin D in West Virginia. So who knows?
Okay, thank you, John.
Hey, Dr. Gilfees, I have a quick question about the Hep B too. And this is for my learning too, if he is actively being vaccinated and it does prompt an increase in his immune response, even if his baseline surface antibody was negative, would that degree matter as much? So I mean, or would you check it again during, I don't really know how long it would take to lose that immune response if he's being vaccinated, since it can kind of cause that. Because I think he's had 2 vaccinations. So would it be a false safety or false comfort?
I don't think so. It's a great question. Kaylee's bringing up a nuanced point. And by the way, it looks like you're being attacked by a monkey. I don't know on the video there. I hope you're okay. But
I know. No, I can't see you.
The hey, so when the differential of isolated core positivity has always been a challenge. Only recently we've recognized that concomitant hepatitis C is a common cause. But one of the most common answers we used to give for isolated core positivity was somebody who had a previous natural infection, who had developed likely immunity, and then whose antibody titer had declined with time. And what you in essence have done is tested that theory and vaccinated them and boosted them probably very high levels. And so if they are somebody who's capable of reacting to a surface antigen, you're on cruise control. This is going to be somebody whose immune system is capable of natural control. And I don't really worry about them too much in that scenario. So, but it's, if he did not develop reactive antibodies, this would be somebody who probably never did develop antibodies and was actually one of the 5% of adults that goes on to chronic Hep B active. So I'm interested in those quantifications, and the fact he reacted is really comforting to me.
Rachel, was there something you wanted to add as well?
Yeah, so I'll just run down the list of the medications here just to go over everything. Super excited, doing a little cheer for Jen as she was running through those. And Kaylee touched on a lot of these, but just to make sure our bases are covered, the atorvastatin, not recommended with Mavorite at any dose. So there, if he's going to stay on the atorvastatin, Mavorite would not be a good choice. And also keep in mind the Zepatier. The max dose that's recommended for that with Mavorite is 20 milligrams. So you don't want to go over the 20 milligrams, the atorvastatin with the Zepatier. No specific recommendations on the atorvastatin with the Epclusa if you would go there. They just have a generic monitoring for myalgias and things like that. And Kaylee touched, all three of them are going to have that interaction with ticagrelor. All these regimens are going to slow down the metabolism, so he's going to be at an increased risk of bleeding, but it's the generic monitoring. There's nothing lab values or anything that you would do, just educate, on the signs of bleeding. And then something to point out too with his pantoprazole, Epclusa technically in their package insert, so I guess from a legal standpoint, they do only say that if you have to use a PPI, the only one recommended is the omeprazole at a 20 milligram dose. So technically that dose of pantoprazole is comparable to the omeprazole, but the package insert specifically states omeprazole only just because they didn't actually study it. They didn't do any pharmacokinetic studies with any other PPIs other than omeprazole. So that recommendation is the omeprazole 20 to be taken 4 hours later, and the Epclusa is to be taken with food. So Epclusa with food and then 4 hours later the omeprazole. The only other two things to touch on here, so his insurance, it looks like he has Medicaid, so both Mavorite, Epclusa are preferred, and since he's genotype 1A, you could do Zepatier, that is on their list technically, but you would just want to do that resistance testing first, just to make sure there's no resistance there to see if you would want to use another agent or extend that treatment from 12 to 16 weeks. And then the only other thing, and everybody's kind of touched on the compensated, I wasn't sure whether you felt like he was compensated versus decompensated, but if you had any hesitation from a decompensated cirrhotic standpoint, you want to avoid any of the protease inhibitor containing regimens like the Zepatier or the Mavorite in that case, because that can kind of tip them over the edge there to the liver failure side. But that's really everything that I wanted to go over. If you have any questions for me.
Okay. Thank you.
Thank you all so much for the feedback. Tammy, were there any questions for Rachel or any other questions you wanted to address before moving to the next part?
So he could go on Epclusa or Zepatier.
I would do Epclusa. This is John.
Epclusa,
I would
okay.
do Epclusa.
Okay. All right.
Again, conceptually, you have somebody who's a compensated cirrhotic. You want to keep him that way. He's got more than one potential for going the wrong way. And I think the Epclusa, the non-protease inhibitor-based regimens are the ones that we all have a tad more comfort with.
And when you said like more blood work, would that be like every 2 weeks or?
Really depends what his Hep B studies are. If his Hep
Okay.
B PCR was negative and his antibody to the surface antigen is super high, then it's routine monitoring in my mind.
Okay. All right. Well, I will get that checked.
So, thank you all so much, and thank you, Tammy, for those 2 awesome cases. Jen, I wanted to quickly turn things to you. I know you had a quick question as well.
Yeah, I have a question about a previous case, but also about this case for John or Kaylee, is about the Hep B. So in general, would you recommend waiting until you have antibody titers on Hep B before you begin vaccines, or is it okay to go ahead and vaccinate when you have the patient there and you're seeing them at an initial visit?
Hi, this is Kaylee. Good question, Jen. I tend to, unless they believe that they've been vaccinated before, since you have them in clinic, I try to just go ahead and give them the first dose.
Okay.
It's really not going to cause any harm to them, but and then go ahead and get tight or get serology at that visit too. Sometimes this happens on occasion, but you may get a false positive surface antigen if you check it too closely to when you give a vaccination. And so if you do get a positive surface antigen, but the rest of the serology is negative, or their surface antigen's positive and surface antibody is both positive, then I would consider a false positive. You might just want to recheck it in a couple months.
Okay.
But I give a didactic in a couple weeks, I think, on Hep B. So I'll try to make sure I can answer all these questions better than.
Thank you.
Yeah.
That's what I've been doing. I just want to make sure that was okay.
Yeah, that's my approach, because you got them there. You don't know if they're necessarily going to come back, so try to do what you can while they're there.
Right. Okay. Thanks. And then Kaylee, I know we're short on time because there's also a presentation, but Kaylee, Mitra had invited me to just have a follow-up question on a patient I presented a couple of weeks ago. And Jean, I think this question is for you. This is a 63-year-old gentleman who has compensated cirrhosis and Hep C, and I got an ultrasound on him, and which did show the cirrhosis, but there was a finding on here that I didn't know what to make of. So it says IVC and hepatic veins are patent, no perihepatic fluid. Main portal vein is visualized. However, there's no sonographic evidence of flow. Clinical correlation advised.
Can you hear me?
Yes.
Okay, great. I couldn't get my speakers to work earlier.
Oh.
I would definitely do an MRI on this guy and just see if you can get flow. I would do the MRI with MRCP and just make sure that you can pick that up, because otherwise, you're looking at thrombus, and that's something that we have to nail down a little bit.
Thank you.
Awesome. Jen, was there anything else you wanted to ask the group before we move to the didactic?
That's it. Thanks.
Awesome. All right. Well, thank you both so much, Tammy, for the cases, and Jen for that follow-up question. Jean, I will pull up your PowerPoint for you and just turn things over to you. Just let me know when you'd like me to advance your slides for you.
Great.
I got you.
Awesome. Cool. Thank you. So I'm going to present on fatty liver disease today. This is not a terribly exciting topic, but it is a topic that, is very prevalent and I deal with on a day-to-day basis. The end result is I talk a lot about diet and exercise. Go ahead and scroll to the next one. I have no conflicts of interest, go ahead, or anything to disclose. So the overviews, I just wanted to touch on, abnormal liver enzymes, the risks for these things, the pathophysiology and why it occurs, NAFLD versus NASH, and then how to manage this. So basically, we're looking at the 3 LFTs that are, very common in our practice. The ALT is the most specific for hepatocellular injury, is what's going to be more indicative of fatty liver disease. However, you will see changes in all of the other numbers depending upon the degree of fibrosis. The AST is liver specific, but it also picks up some cardiac and some skeletal muscle in there. So a lot of times if you think it's fatty liver and this guy's really fit and he's very active, and if you draw an aldolase level, that'll sometimes help narrow that down because the aldolase looks at that skeletal muscle driving that AST. The alkaline phosphatase talks about primarily liver and bone. So people with hemodialysis will often present to our clinic with elevated alk phos. They're worried about fatty liver disease. More than likely, they're having a component of bone loss that's driving this alk phos. But we do the entire workup just to make sure that we're not missing anything. We get a lot of referrals for an alk phos of 139, 163. These really aren't significant numbers. Until they get over 180 or 200, we don't really address them. A lot of people like to do this fractionated alk phos. I came from a liver transplant center in Texas. We never ever drew this fractionated alk phos, and the reason being, it's not really specific to the liver. But when it gets drawn, we have an impossible time trying to convince rheumatology, ortho, and other people that it's not liver, because it nearly always says that it's liver, but it's not really specific to the liver. Go ahead and switch pages. Thanks. So, you know, the AST should be higher than the ALT. Predominantly, both of these are pointing at hepatocellular injury. If the alk phos is predominantly elevated, then this is cholestatic or obstructive. Thinking about, you know, gallstones and pancreas and bile ducts, those kinds of things. Go ahead and switch pages. One-time abnormality, we see these spikes sometimes. As long as they're fairly mild, it's not like 1,000 or something, then we don't really do anything with it. We just say trend them and see what they're doing for a while. If they are prolonged and it's, you know, mild, 30 or 50, we don't necessarily think you have to do anything else. But if it starts climbing to 80s and 100s, then I would definitely say, you know, he needs additional workup. ALT should be the greater. If you're seeing that AST that's higher than the other one, you want to be thinking about alcohol. You know, they often tell you initially that they're not drinking that much. You got to really ask a lot of questions. And I'm sure everybody has found that it's probably better just to assume that they're drinking and say how much instead of saying, are you? You know, because I think that they're less offended when you just assume that they are. Sometimes other illicit drugs will show up in the same or a similar pattern with that AST being elevated. Certainly alcoholic cirrhosis will show up with an AST being higher. Sometimes cirrhosis, if they've had an alcohol problem all along, sometimes that cirrhosis will continue that AST elevation higher than the ALT. Go ahead. So these are the risk factors that I go through with all of my patients. I'm sure you guys are talking about all of these things as well. I don't think anything is, you know, too earth-shattering here. The only thing that I probably ask that most folks don't think about, you know, talking about is maybe this participation in the military. You know, everybody that goes, or nearly everybody that goes to the military, they go through a shot line. And to this day, you know, they go down the line with this injection gun or vaccination gun, and they infect everybody after the first guy that was infected. So this is not something that's new and earth-shattering, but it's not something we really think about a whole lot. So these are all the risk factors that I worry about for liver disease. Specifically though, for fatty liver, I'm more worried about the metabolic components. And a lot of times you'll see people, they'll tell you, I don't have diabetes. I don't have cholesterol problems. I'm not taking any medication for this, but they really do. It just hasn't presented itself in the labs as yet. And so if it hasn't been something that's been on somebody's radar, it's just not, you know, being addressed yet. Go ahead. DILI is always a big risk, and everything, it seems like, you know, causes drug-induced liver injury. As a general rule, I tell everybody to avoid herbals completely. Chinese supplements, herbal supplement, muscle building supplements, dietary weight loss supplements, all of these things will present and look like fatty liver disease. It makes the liver numbers go up, usually in a hepatocellular injury pattern, so you get that AST, ALT elevation. Sometimes if it's prolonged, it'll leach into that alkaline phosphatase as well. So again, avoid the herbal supplements. Nsaids, when you don't have cirrhosis, Nsaids are okay in moderation. They do cause ulcers and bleeding, and we see that really, really frequently here with our non-cirrhotics. So most people that end up in my clinic, I tell them not to take Nsaids at all, whether they're cirrhotic or not. But you can use them, you know, conservatively, obviously. Illicit drugs always show up on liver injury, unfortunately. Even marijuana, and I have a hard time convincing patients that marijuana causes intractable nausea, causes intractable vomiting, causes liver numbers to go up. Everybody thinks that this is completely benign, it doesn't cause any problems, it's completely natural, and you know, it needs to be legalized. So I have a really hard time telling people to quit smoking pot. There are some common medications that will cause DILI. Amiodarone and hydrochlorothiazide are probably the two that I see more frequently. Nitrofurantoin, though, a lot of women will come in with this one, and I just basically take them off of that, and amazingly, the numbers will normalize. But usually these folks, you know, if you want to sort of characterize folks, they come in, they're female, they're overweight, they may or may not have a singular sexual relationship, and they're on this kind of a post-coital nitrofurantoin irritation medication. Take them off of it because it just causes problems with the liver over time, causes fibrosis and causes cirrhosis over time. Generally speaking, antibiotics, antifungals, and antiepileptics nearly always cause problems with the liver, and if we can't get them off of these things, it's just something that we have to sort of negotiate, you know, what's going to be the new high, what's going to be the appropriate medication within the class, those kinds of things. Don't take your fatty liver people off of statins. This is something we see that happens all the time. People are very nervous. Statins cause LFT elevations. They do, but they don't cause enough to worry about versus having a heart attack or a stroke. So I'd rather them take this unless the LFTs are greater than 5 times the normal. Don't stop your statins. There's a database on the bottom here on this page, Liver Tox. This is a great website. You can pull it up. It's completely free. You can plug in any medication, any herbal, and it'll pull up any cases that have come up for fulminant failure. And it'll give you like the breakdown of how they had fulminant failure. It'll tell you how many cases in general they've seen this on. You know, some of the more bizarre things like black cohosh. I don't know if anybody's heard of that, but that's something that is frequently prescribed by gynecologists for night sweats. This medication is a known hepatotoxic medication, has caused fulminant liver failure and death. Okay. So we don't recommend any herbals unless you really are watching this person really closely. You can go ahead and change. So for fatty liver and NASH, you know, what's the difference? We're going to get into the nuts and bolts of this, I guess. You know, I get told a lot that this is just fatty liver. It's just, I'm just overweight. I just have diabetes, whatever. And that's really the mentality of, I think, all of America. You know, our incidence of obesity is much higher than the rest of the world. The numbers are there on the screen. But it's not just fat in the liver. And I try to tell people this because fat in the liver causes inflammation, causes scar tissue, causes cirrhosis, causes decompensated liver disease and death. And they don't get it. You know, fatty liver leads to liver cancer, leads to death. They just can't make that connection. Liver transplant is expected to be done for fatty liver as the #1 cause in the next few years because Hep C is being treated and cured. Go ahead. So what's the difference? You know, the AASLD, I don't know if anybody's familiar with that website, American Association of Liver Disease. they say that, you know, fat in the liver is diagnosed by imaging or by histology only in the incidence that nothing else is causing it. So, you know, certain types of Hep C causes this, certain medications will cause fat deposits into the liver, so that's not fatty liver then, okay? But NAFLD and NASH, what's the difference? NAFLD is diagnosed usually with imaging. You can see it in an ultrasound. You can see it in the labs. The numbers will go up. It doesn't require a biopsy, but you do have to rule out everything else. You got to rule out iron overload, copper overload, etc. NASH specifically is only diagnosed on biopsy. So a lot of times, I feel like it's a real misnomer to say that somebody has NASH. They've never had a biopsy. You can't just make that assumption. It's always NAFLD until it's proven with biopsy. The NASH itself is changes inside the cells, not just within the organ itself. It's actually a change within the DNA of the cell that causes change in there. You can go ahead. So, you know, the general rule for fatty liver, a third of people will progress to cirrhosis, a third will stay where they're at, and a third will get better. Those people that get better are the ones that lose weight. And honestly, 10% body weight loss is significant, okay? So if you got a 200-pound person, 20 pounds in 1 year's time is great. Going to reverse that, and that's going to cause that fibrosis risk to go down significantly. Both of these things, though, are reversible lifestyle change, okay? NAFLD is less severe than NASH, but again, remember that NASH is within the cellular structure, so you've already had that penetration of the disease process. Go ahead. Thank you. You know, alcoholic fatty liver disease looks like fatty liver disease, so you just kind of have to tease that out. I get told all the time that I only drink beer. That's not alcohol. Well, yeah, it is. I only drink hard cider. That's not alcohol. I only drink my homemade whatever. It's all alcohol. If it has any alcohol in it, it's considered alcohol. And I really feel like, you know, I don't know if it's America or the world generally, they really don't acknowledge alcohol unless it's wine or hard liquor. Alcohol is metabolized through the liver. It breaks down, it looks like fat, okay? So it looks like NASH, it looks like NAFLD. If you stick it under a microscope on a biopsy, you still can't tell the difference all the time. We used to do biopsy consistently for alcoholic fatty liver disease, and it would say hepatocellular ballooning and deconstruction of the cells and Mallory-Denk bodies, et cetera, et cetera. But now we're finding that those are actually seen with fat in the liver as well. So just regular fatty liver will show that stuff. So it's hard to differentiate what is the difference. It's really by, you know, the talking to the patient, by the assessment, by the history. Acute alcoholic liver disease versus alcoholic fatty liver. Acute alcoholic hepatitis will cause death. It's life-threatening. It's the hospitalization required and probably, you know, steroids, etc. You can have chronic ongoing fatty infiltration of the liver, chronic ongoing alcohol use, and still get an acute alcoholic hepatitis on top of that. And that's life-threatening as well. But you got to think about all those other things, especially if they have cirrhosis underlying. Acute alcoholic hepatitis or acute fatty liver can look like cirrhosis. If they quit drinking, all of it resolves and they don't look like cirrhosis anymore. You can go ahead to the next page. This is just a cute little cartoon to go with the website. This is for the alcoholic versus non-alcoholic index. None of the testings that are out there short of a FibroScan are really that accurate. But when you take these things in consideration with the rest of the history and other testing, they're all pretty good. They're all about 80%. So they're not, like I said, not great, but usable. Go ahead. So you're going to diagnose it, you want to stage it. So you diagnose fatty liver with labs and an ultrasound. Unfortunately, I see ultrasounds that'll say liver, normal, spleen, normal, pancreas, normal. Well, what's normal? you know, I want to know what the size of it is, what the texture of it is, what the shape of it is. I want to know all of these different things. Is the blood flow going in the right direction? Can they even see blood flow going in the right direction? So an ultrasound that just tells you everything is normal is not a good image, okay? Elastography is a great tool these days. Unfortunately, it's just not widely available. But elastography will actually stage your fatty liver. So it'll give you a nice imaging for the ultrasound of the liver, but it'll also stage your degree of fibrosis, which is really lovely because then you don't have to do biopsies and all that stuff anymore. The only problem is with elastography, it's not effective for some classes of people. If you smoke a lot, if you have really bad high blood pressure, if you've been transplanted for your liver, if you carry all your weight in your middle, it's not going to be a great test for you. But otherwise, this is a really great option, and we prefer this to biopsy for the most part. Next page. So I mentioned all the other testing that's out there. There's all different kinds. I see a fiber test here in West Virginia a lot. You know, I see these other scores, the APRIs and the FIB4s and all this stuff. None of it is, like I said, none of it's really greatly accurate. But when you use it in conjunction with history and all of the other lab testing, they're adequate. They really are. Even though the specificity or the sensitivity might not be as high as you'd like, these things work. Just today, I mean, I order these things too. Just today, I ordered a HOMA-IR. The guy has moderately elevated LFTs. I think he has fatty liver disease. His imaging shows that he has fatty in the liver, but he doesn't have diabetes. He's not overweight. His cholesterol is 200. So, okay. His parents, mom has diabetes, that's it. Dad doesn't have any medical problems, but I think this guy has fatty liver disease. He just doesn't have any clear metabolic problems. So I think he has brewing pre-diabetic syndrome, and the HOMA-IR does a good job of telling us that. I mean, ideally, LFTs, elastography, biopsy, those are the best tests you can get, okay? Go ahead. Oh, goodness. Management. It's like I said, I feel like I harp on diet and exercise forever and ever. Most folks, I tell them, you know, on your smartphone, MyFitnessPal, Lose It, Weight Watchers, just about any of the exercise like Under Armour apps, all these different apps are great because without changing anything in your diet, if you track how many calories you're eating and cut it by 500 a day, I don't care if you eat 5,000 calories a day or you eat 1,500 calories a day. If you cut it by 500 calories a day, at the end of the week, you'll lose a pound. I don't want people to lose more than a pound or two per week because if you lose the weight quickly, you gain the weight quickly. I want this to be sustained for long-term success, okay? Some people like referrals to dietitian. What I find are fatty liver patients are not very open-minded to that for the most part. They get kind of defensive. Everybody just says I'm fat. Well, it doesn't matter. You can be morbidly obese and not have fatty liver, and I try to tell people that. I see people that are incredibly thin. They look like they're fit, but they still have fatty infiltration of the liver. Genetics plays a role. Diabetes, hypertension, cholesterol, triglycerides, activity level, weight gain over time. All of these things contribute, and all of these things have to be managed to the best of their ability. Again, don't stop your statins. Imaging, once we know it's not cirrhosis, you know, every 2 to 3 years, unless they have significant change, you know, the numbers spike up, or they lose 60 pounds, then certainly do, you know, additional imaging to see where we're at now. Okay. Tylenol's fine. I get told every single day that you're not supposed to take Tylenol if you have a liver problem. That's old information. Tylenol is safe in the liver. We know that it causes liver failure, liver death, but if you take less than 2,000 milligrams per day, it's safe and we know what it does. It's always safe to take Tylenol. I'd rather not somebody that's drinking a lot to take Tylenol, but they don't have a good option for anything. They shouldn't take, Nsaids either. So I'd rather them take Tylenol as well, but they really should limit it to less than 2,000 milligrams a day. Again, with the herbals, avoid them if you can. I don't tell people to do any diet at all. Like I mentioned a minute ago, they can do Mediterranean, they can do a DASH diet, they can do a diabetic diet. I don't care. I try to avoid people talking about a keto diet. I think this is really dangerous and it can cause pancreatitis. And we don't want them coming back for that into our clinic. We see enough folks without adding that into the mix. So really anything they want to eat is fine, is what I tell them. Just decrease the calorie intake. I don't even really focus so much on exercise for these folks, because I feel like it's such a huge concept to start thinking about how much you eat every day and trying to change that it's too overwhelming to try to do that and do exercise and try to do 20 minutes and try to do 3 or 5 times a week. It's just too much, I think. So really, I try to just get them to start tracking it on their phone and then decrease their intake. I think that works the best, because then they focus on 1 pound a week instead of, oh, I got to lose 50 pounds. It's too hard to think about. I can't even think about 10 pounds. That just stresses me out. Okay, next page. So when in doubt, send them up here. I'll talk to them about it. And next page, I think is just, my references. So AASLD is a great option for y'all if you're interested in reading up on all this stuff. They do some great write-ups on it.
Thank you so much, Jean. That
I'm
was
sorry,
awesome.
I'm like way over time.
You're totally fine. I know this was a super highly requested didactic, so we really appreciate it.
Thank you.
Thank you.
Any questions, comments, or thoughts you wanted to share with the group? Anyone? We got a thumbs up from Dr. Rexroad and a chat from Tammy saying thank you.
Thanks so much, Jean. This is Kaylee. We really needed this didactic, so really
Thanks,
thank
Kaylee.
you. You're awesome.
Thanks.
Yeah, it was really awesome. Thank you, Jean.
Oh, thank you.
Well, if there are any questions for Jean after the fact, just shoot me an email. I'll make sure to send them her way and have them addressed for you guys. So thank you all so much. This has been such a great session. I know we're a little over, but it's always such a delight to be here with you guys. So thank you. Just a couple housekeeping announcements. Our next session will be on November 12th. And I know we had a lot of discussion about hepatitis B, which is going to be the next didactic from Kaylee. So keep an eye out from that reminder. I'll be sending out in about a week or so. So thank you all so much. We'll see you guys next time.